Good evening once again to participants on this call, especially to our teachers and trainers and as well as our colleagues. I'd like to welcome us once again to another end of the month meeting of the Nigerian Society of Rectal Disorders. My name is Dr. Ademolade. I'm the Vice President of the Society. I'm standing in for Dr. Adejimo, the President, who will be coming late for some personal reasons. Today we have a case presentation on the management of a mid-rectal tumor. It's to be taken by a senior lecturer and a consultant general surgeon from the Nnamdi Azikwe University, and Dr. Ochonma Amobi Egwuonwu. He's already standing in the wings to give his presentation. So as we usually do, after his talk, there will be a Q&A session discussion and to be moderated by either Professor Shinowo or Professor Egwuonwu. Thank you once again for listening. Is our presenter ready, sir?
Good evening, senior colleagues and colleagues. I'll be making a key presentation on management challenges of a mid-rectal tumor. The patient I'm presenting is Mr. A.A., a 48-year-old university lecturer from MBC in Imo State. Presented to us 1 year ago with 5-month history of bleeding per rectum, frequent loose stool, and progressive weight loss. Initially noticed the frank red blood was mixed with stool, the associated feeling of lightheadedness or fainting attack. The quantity of blood was just not so much. It is estimated to be about 10-15 mils. Later, I started passing frequent loose bloody mucous stool, which worsened progressively to about 20 times per day, compared to the initial twice daily. This was associated with mild abdominal discomfort with tenesmus. There was no preceding history of change in bowel habits before this time. He also complained of progressive weight loss. There was no associated yellowness of the eyes, cough, or breathlessness. No family history of colorectal cancer or any other malignancy. It's not a no hypertensive or diabetic, no previous surgical history. Takes alcohol occasionally, but does not use tobacco in any form. On examination, he was not in obvious distress. He was not pale. He was anicteric, not dehydrated, febrile. Abdominal examination revealed a flat abdomen, area of tenderness. The liver spleen was not palpable. The kidney was not ballotable. Rectal exam revealed a circumferential mass at 8 cm from anal veg. Other systems were essentially normal. Following this evaluation, history and examination, we ordered a colonoscopy, which revealed a circumferential esophageal mass in the rectum that was noted at 8 cm from anal veg and extends about 8 cm upwards, but no longer involving the entire circumference. The rest of the colon was normal, including the cecum. Carcinoma embryonic antigen that was done was 3.1 nanogram per mil, as opposed to 0.5 to 0 to 5 nanogram per mil range. It was elevated. The histology of the bowel specimen we took during colonoscopy was reported as well-differentiated malignant glands infiltrating into the underlying fibrous tissue stroma. Also seen were surrounding areas of tissue necrosis. In the rectal MRI, which was reported as this, that there was a long segment esophageal solid lobulated mass in the upper to the rectum over a distance of 7 cm with a wall thickness of 2 centimeters. There was no serosal involvement. There was no extra oral vascular invasion or perirectal fat lymph node enlargement. No involvement of the prostate or urinary bladder, no ascites, no evidence of pelvic bone involvement. The impression from the rectal MRI was upper to mid-rectal CA with clear resection margin. No evidence of local infiltration or invasion. Abdominal ultrasound, no liver metastasis, no ascites, as already stated too by the MRI. Chest X-ray was essentially normal. The diagnosis of mid-rectal carcinoma at stage 2A, T3N0M0. The treatment option we offered patient was a neoadjuvant chemotherapy to be followed by surgery. But the lecturer declined vehemently. So due to distressing diarrhea and tenesmus, that he would prefer get surgery. despite explaining the whole benefit and disadvantage. Wasn't also happy with the duration of the neoadjuvant chemotherapy. So we consider an option of surgery to follow by chemotherapy. We offered him that, and at surgery we did a low anterior resection to colorectal anastomosis using a circular GI stapler. This time, macroscopic margin we were able to achieve a resection was 5 cm. We also gave a protective loop colostomy. Trial finding was a restricting tumor with hourglass appearance noted at the mid-rectal. There was no obvious liver or peritoneal deposit. The histology of the specimen said gross examination, 19 cm segment of intestine with obliterating tumor at one end, external diameter 3.5 to 6 cm. Careful search with 3 lymph nodes. Microscopic examination said well-differentiated malignant gland extending from the mucosa into the muscularis propria layer. Margin of resection were not involved. The 3 lymph nodes shows features of reactive hyperplasia. So they made a diagnosis of well-differentiated infiltrating adenocarcinoma, pathological TNMCG of T3NO-MX. He was discharged home on the 7-day post-op. Plan was to commence adjuvant chemo 2 weeks. He came 2 weeks post-discharge, said he was not ready for chemo. He returned to the clinic 4 weeks later, said he was not interested in chemo again because of what he read about it. All effort to persuade him to share his concern failed. He insisted his only concern just to reverse the colostomy. Eventually, after frequent persuasion, he refused. Colostomy was reversed 14 weeks post-operatively. He was discharged on the 4-day post-op. 7 months later, which was about 3 weeks ago, he presented with complaint of alternating diarrhea and constipation of 1 week duration. Rectal exam revealed a mass at 6 cm from anal veg. Abdominal CT done 3 weeks ago noted abdominal irregular nodular rectal port thickness, seen over a vertical distance of 7 cm, port thickness of up to 22 millimeter, involving previous surgical anastomotic suture site. He also noted enlarged metastatic lymph node in the perirectal fat with a short axis diameter of 8 millimeter. Homogeneous enhancing normal liver spleen, no ascites. Other areas were essentially normal. They made a diagnosis of regional recurrence. Did a colonoscopy that revealed circumferential exophytic mass at anastomotic site 5 cm from anal veg and does not extend proximally, leads to contact. Biopsy was taken. Other segments of the colon were essentially normal. This is the colonoscopy picture at the site of the local recurrence. We are waiting the histology report. We are waiting the result of CEA that we requested for. So he was counseled on the need for chemotherapy, which may be followed up by AP resection if his tumor responds. He is inclined to consider chemotherapy, still thinking about it, but AP resection, he said, is not an option. I called him even last week, asking for the histology report. He said he will come when he's ready. So the challenges we have now is in this management, the absence of, we don't have a rectal tumor board in the institution, refusal of neoadjuvant chemotherapy at the first presentation, refusal of adjuvant chemotherapy following low anterior resection, and the locoregional recurrence. The big question is, what is the next best option of management for these patients? Present to us. What do we hope to gain, achieve? And with his difficulty, it seems the knowledge he has as a university lecturer has not been for him. Thank you.
Thank you very much. Thank you very much. Thank you. Can you all hear me?
Yes, we can hear you. We can hear
you. I mean, the patient he has just presented is a typical patient we see in Nigeria. One is a gentleman, is a patient, Mr. AA, that presented to the hospital following 5-month history of sporous diarrhea, rectal bleeding, sporous diarrhea, and rectal bleeding. Right. He had he had an MRI, but I didn't really, what the part of the MRI I didn't get was the staging of the MRI. Was it a T2NO? I didn't get that clearly. I didn't get that clearly whether it was a T2NO. He had an MRI and it was offered. I don't know whether you have an MDT in your institution. Either way, he was offered chemotherapy. He refused. We're just wondering why it was not offered chemo radiation initially, but that doesn't really matter much. But he was offered chemotherapy. He refused. Then he had surgery. And the surgery was a low anterior resection, and the low anterior resection was also protected with a colostomy. I'm going to assume it's a transverse colostomy. He didn't mention that. Then patient insisted on having his colostomy closed. Colostomy was closed, and it subsequently developed a recurrence 7 months after the initial surgery. The question we should ask ourselves, one, there are two things we should need to ask ourselves. I think we need to look at the pathology report again. So actually, we need to have a meeting concerning the pathology report because this seems to be a very early recurrence. If it is indeed a recurrence, whether it's an early recurrence, and that is one. Two, what should we do for the patient? I think we should all sit down and discuss with the patient, not just one. We should have a multidisciplinary meeting with the patient, telling him the need to have appropriate treatment. I think the appropriate treatment is what we should all discuss here. I don't want to jump the gun by starting it. I think the appropriate treatment for him is what we should all discuss here. I think I should leave the room open for everyone to talk. Let me see.
Yes, Dr. Shinowo.
Yes, sir.
Yeah, I was just, there are a few things that really strikes me here. The first one is the lymph node retrieval of 3. And those lymph nodes just show the reactive hyperplasia. Yeah, that's the first thing. And then the other question really, and because I'm just concerned, maybe the power of persuasion, because there are sometimes offering this treatment, maybe should we be more persuasive in really making people understand what the downside of not having adequate treatment, because this young man seems like somebody that should have needed neoadjuvant chemoradiation. And then maybe the information, because he refused it because he was having, the diarrhea that was really causing him distress, because the chemoradiation would have actually controlled that symptoms if he had radiotherapy. That would have controlled the symptoms of the diarrhea. But then the other question is the very early recurrence. The histopathology says that the resection margins were clear. Yeah, but that again will bring a question in terms of 7 months for early recurrence. The recurrence was quite early, I would have thought, for margins that are
clear.
Yeah. And then, the question you then asked, and Dr. Shinowo, is how should this patient be managed? Yeah, I think, going back to do another surgery is just not going to be, it won't be to his favor, because that area, you just 7 months is still very early. And I think the treatment this man should be getting at this stage will be what he should have got the first time, chemoradiation. That would be and now, unfortunately, his stoma has been reversed. It just...
Yeah, I agree with you. Can I go ahead? I agree with you entirely. Actually, I didn't want to jump the gun by stating what I want the patient to have. I think the patient you have, one, patient should come to it should have a multidisciplinary, during a multidisciplinary meeting, it should be told, one, the ideal thing for you to have is just, I think the best is just to assume we're treating a new disease. We're treating the disease ab initio.
Yeah.
One, you should have a chemoradiation followed by total neoadjuvant therapy. Then we reassess the patient. I think that's what I will offer. That's what I will offer the patient.
Yes.
Unfortunately, like rightly pointed out, the stomach has been closed.
Yeah.
I don't know where he got his initial information from. I mean, why he insisted on having surgery up front. I think he should have been persuaded into having chemoradiation because, like rightly pointed out, chemoradiation will have mitigated all the symptoms he had. Chemoradiation will have mitigated the sporous diarrhea.
Yeah.
It will have mitigated the sporous diarrhea. I think there's also a problem with the histology report. I think there's a problem with the histology report. I think there's a problem because the histology report stated that there are clear resection margins.
Yeah.
The lymph nodes that were harvested, they harvested only the lymph nodes, and all the lymph nodes showed reactive hyperplasia. There's something that it's extremely difficult to connect the dots with this patient. It's extremely difficult. But either way, he has not had appropriate treatment, sir.
Yeah, I guess maybe this brings to mind what we're talking about in terms of harmonizing the reporting system, because the information contained in the histopathology report here, it does not tick all the boxes. Because if we are to use an adequate reporting system, it needs to talk about the resection margin. You want to talk about the circumferential resection margin. You want to talk about, was there a total mid-rectal excision? And then the lymph node, you need to talk about that lymphovascular involvement needs to be addressed. So all those things, maybe this is really what we should be doing. And then that again brings up the issue of the multidisciplinary team meeting. I think decisions should be guided by should be driven by the MDT or MDM rather than patients coming. This is not an a la carte menu that patients just come and choose what they want, because you are not doing them any service. Like this man, 48-year-old, who has a lot of investment and has a lot of value to offer to the society. So he's just such a huge loss, and this is the kind of person that should have had optimum treatment at the beginning. And you see, if a multidisciplinary team meeting makes a decision, even here, if patients decide they are not going to, I'm going to tell them, look, we've discussed it at the MDT. This is the decision of the MDT. I cannot go against the decision of the MDT. And most of it, they have to agree to doing the right thing. We cannot negotiate a poorer treatment with no poorer outcome, because the patients, they can't choose, because you are the doctor and they just can't be choosing what they want. I don't know what your view is about that.
Can I say something, bro? So, interestingly, this patient it appears sometimes whether our education helps. I have currently two scenarios like this. One is a barrister. He had intestinal obstruction at the peripheral hospital where he had a right hemicolectomy. It was a right tumor. After the surgery, he was offered chemo. The barrister vehemently refused to accept the chemo from that center until he developed metastasis. Another colleague, a family physician, directed him to us. We had to persuade him again to see whether he would start chemo. He reluctantly accepted chemo alongside Avastin. He got just 2 courses and felt relief of all his symptoms. We invited him, we need to continue this for a long time. You can afford it, let's go ahead. Till today, the barrister has not shown up. I've called the colleague to speak with him because he's his friend. He said he has tried to persuade him to continue treatment. He refused, despite explaining all the consequences to him. This patient, there's no MDT in that center, but indeed, we had a good conversation with him. He gave the impression that after the surgery, he will agree to continue with adjuvant chemotherapy. And he refused and refused. Despite, I refused to reverse the colostomy earlier, that he must accept chemotherapy. He vehemently refused, that he would not. We had to reverse it, and he left until this incident. He came back feeling remorseful, and even with he's a bit remorseful, not even that he's ready to accept any treatment option, still a bit choosy. So it becomes a challenge, like when we don't have an MDT, whether with that courage to say, we have offered you this, if you don't accept it, then you can go to another center. I don't know whether I've come of age in Nigeria to do that in a situation like this, because that would be quite helpful. If we tell him that this is the only option, if you don't want, you can go. Most likely, we may be able to blackmail him into accepting that treatment option. That if he goes to another center, he's also told the same thing. It could help.
Yeah.
But otherwise, it's really a challenge. Sometimes you try to strike a balance between what you think is the best for him and what could be a middle ground for what is acceptable to them. So this is really a disaster. I told him that this is a disaster that he created for himself and for all of us, that I don't even know where to start, how to help him at this point.
Yeah, I guess what you're saying is so correct. Yeah, I mean, you're absolutely right. I can see your own the dilemma you find yourself in this kind of situation. But I think this is an opportunity for us actually to have a unified MDT that, you know, people just can't shop for a doctor that will do what they want. We owe our patients a duty of care. You know, he is a lawyer. And if you had a case to go to him and tell him to judge your case, he's going to tell you what the likely outcome is in court. You know, you don't have a right to choose what you want. He's a professional and you are a professional. And I feel so bad. Yeah, this is just such a lost opportunity that could have. Okay, I think Dr. Shino, we're over to you. I think there are some questions.
Yeah, there. Okay. Two things. Good afternoon and good evening, everyone, again. Like, I think there are two things we should all agree on. There are two things we should all agree. Yeah, I think there are two things. There's one particular thing we should all agree on. I don't think we should allow a patient to dictate what we should do for them. I wouldn't have operated this patient in the first place. I wouldn't have operated this patient. I wouldn't have operated this patient. I would have told him to go and get a second opinion from another person or to go somewhere else. There's no way I would have operated the patient because the standard treatment is initial chemoradiation, adjuvant therapy maybe, and surgery. Right? I don't know what the
Dr. Shino, we can't hear you.
I'm here.
Okay.
Question one is some of them are actually comments. Some of them are actually comments. The first question is, what's the main concern about APR? Is there a concern about permanent colostomy or what? I don't think we should be discussing APR here. Can I go ahead and answer the question, sir?
Yeah, go ahead. Yeah.
Yeah, I don't think we should be discussing APR yet in this patient. We should be discussing APR yet in this patient. We should first offer this patient the initial treatment he wants. He should have chemoradiation. He should have chemotherapy. Then we should also look at the histology report. I think that's the first thing we do. After he has had those treatments, he has had chemoradiation, he has had chemotherapy, we can now restage him. He can now have a staging MRI. Then we now decide what treatment he will have. So to start saying he's going to have this or now, I don't think we should do that now. I don't think we should do that. The second question, the patient has the right, somebody is saying that the patient has the right to say what he wants, but the physician must only do the right thing. Of course, I agree with you. All you need to do is to tell sir?
Oh, absolutely. I'm listening.
Yeah. All you need to tell the patient is, this is the standard treatment. If you don't want the standard treatment, you need to go to somewhere else. I'm not going to offer you what is not standard. This same patient can sue you in future. of course, I concur with Dr. Etu, who said the patient should have had chemoradiation before surgery. The histology report also, the histology report did not talk about tumor infiltration or resection margin. I think the histology report, they didn't follow it did talk about that the resection margins were free, but I think there was still a problem with it. I think there was they didn't follow the standard protocol of they didn't follow the standard protocol of they didn't follow the standard protocol of reporting. They didn't follow the standard protocol of reporting.
Yeah. Any other comments? And
somebody is saying, how is it to set up an MDT in a center? I think setting up an MDT is not, I don't think an MDT in these days, thank God for COVID. Thank God for COVID. COVID made a lot of things easier for us. Quite a lot of things can be done by Zoom these days. This meeting is been yeah. Thank God for COVID. COVID actually changed a lot of things for us. With a case in point, this what you are doing now is like an MDT on this patient. It's like an MDT. There's not a true MDT, but it's like an MDT on this patient. COVID makes things a bit easier for us. We can really have a Zoom MDT on all patients. In my institution, all our patients, we don't have a physical and in-person Zoom meeting. We have a Zoom MDT, sir. Hello,
that's
sir.
interesting. It's interesting. Can we use this opportunity to see how we can enlarge or extend that invitation to other centers? Like this case, maybe Dr. Egwuonwu would have benefited from discussing this at the MDT, Zoom MDT, prior to this, and then he can have more information, or you would have had more support, moral support to go back to this patient and say this. Maybe we should begin to think of that. It doesn't have to be in person, but we thank God we have Zoom facilities now, so we can do that. At least that is something we can start off immediately. And then the other thing I will encourage is every surgeon in the hospital should take it upon themselves to begin to co-opt people into their MDT. Talk to your pathologist, talk to your radiologist, and talk to your medical oncologist. And if you have to buy lunch for them to do it, just buy lunch for them. But it's a good investment. But, something I think we should begin to do,
Please, I'd like to. Okay. If while we are making an effort to other centers to set up MDT, I will suggest if there are centers who are willing to accommodate some of our members here who may not have MDT in their center, if they have cases like this, that they need their input, whether there are some anchor person we can reach out to and pass it by them, whether they'll be willing to discuss it with him in attendance at the MDT, it could help too, so that we can tap or benefit from other institutions.
Yeah, Dr. Sino was here, so
I think they can get in touch with me. They can get in touch with me. I don't think I have any problem. They can get in touch with me. They can get in touch with me. I will organize. They did that. They did an MRI. They did everything they needed to do for this patient. The patient had an MRI. The patient had a CT scan. He did everything he needed. The only thing is he didn't have the appropriate treatment.
He refused appropriate
treatment. He didn't have the appropriate treatment. All you need is you can reach. He refused appropriate treatment.
Yeah.
He refused appropriate treatment. He had an MRI. He had a CT scan. He had an MRI and he had facilities for chemotherapy. And he refused. Or I don't know whether chemotherapy or chemoradiation. He refused. He had all the opportunities.
Yeah,
I think for now, I think we should start with. I think the patient should have. I think we need to have an. I think the patient should have an MRI of the pelvis now, so we can assess him and start and decide what's the best treatment forward for him. Most likely, maybe total neoadjuvant therapy or initial chemoradiation. It may require a colostomy. I really don't know for now. At least it may require a colostomy for now as well.
Please, sir, what would be the reason for the colostomy at this point, sir?
I don't know. Is he obstructed? Yes or no?
No. Currently, no, it's not.
It's not. I mean, it may not require a colostomy. It may not require a colostomy, but it will require. I think maybe we should start with an MRI for him. You should have an MRI of the pelvis. It may also require an MRI of the abdomen now because he has a recurrent. I don't know whether he has metastasis to the. It may also require a CT scan of the abdomen as well. MRI of the pelvis and a CT scan of the abdomen.
Yeah, abdomen, in fact, a CT tap, just to assess. But Dr. Moradion has a comment. Dr. Sinowa, I don't know if you saw Dr. Moradion's comment there. Or Dr. Moradion, are you, and Dr. Rowan, can you talk?
Good evening, everybody.
Yeah.
Can you hear me?
Yeah, we can hear you.
Yeah, we can hear you.
What I think we can do is I see some of these things are very basic facts. It's not difficult to get the pathologists on board on some and for unknown reasons. But I think what we can do as a society, we should try as much as possible. If we can, it will make a lot of difference. If we can create a small arm of this group that will be by pathologists. We will beg our international faculty members to get pathologists on board to have a small meeting with our pathologists on a regular basis. If we do that, we can also help them to standardize even their reporting for us. We can all get them on board. If they want to get on board, become better. And in the near future, let us make it a possibility that anytime we want to present any case, even a surgical case, pathologists will have a word in it. They will come and present, even in the reporting. The radiologist should come. So, in other words, we will have a robust discussion. We have somebody in the know about that particular case. I can present, their reports. But if they are doing it themselves, we can put the question directly to them because they are the one presenting such information. It will also help to draw them into our discussion all the time. So if we have the radiologist, if we have the pathologist, if we have the radiation oncologist in presenting this case we just did today, we will have a different light entirely. We will have a different comment. So I think that is what we should do. It may be difficult for us going forward, but I plead with our international faculty members, if you can get the pathologist on your own side, let us try and create even a small forum for the pathologists. It will be the National Society of Colorectal Diseases, quite all right, but purely a pathology discussion. They can have their meeting at the normal time. We can bring them in. In so doing, we are just trying to standardize the type of care that they need to report in. Because the challenge here is that sometimes some of those pathologists, some of them are bigger than us in terms of cadre as surgeons.
Okay.
So talking to them is difficult.
Right.
Some of them are junior to us. If we talk to them, the senior ones within, we say, how can you go and listen to the surgeon? Report for you to report and go on. So I think that we can think about that because the essence of this association is to start standardized care for our patients in Nigeria as an entity. So I think that's the area we should be looking at. The comments from Dr. is well noted. That is standard. Whatever is to be done for the patient should be stated clearly. And as a doctor, we should be able to put our foot on the ground. This is what the care is. Because when things start failing, the patient comes back to you again and tell you, doctor, you did not tell me this. You did not inform me about this. Because the patients are knowledgeable more than we think. They also read. So we should insist that this is the treatment that we want. But then the patient check on another one or two doctors ahead, they will come back to you because you told them what the facts are. So I think we should only put our foot on the ground. Now, patient cannot come and tell us, I want this, when you know that in the future, it will compromise the patient. I mean, after 7 months of surgery, patient coming back with recurrence, I mean, the doctor will be blamed down. Anybody will blame the doctor, including the patient himself, who desire to have the kind of surgery that they want. So thank you very much for the presentation. Thank you for the comments so far. Good evening, everybody.
Yeah, I think there are two hands up there, but just to comment on what you said, Dr. Irowa, it's just that for international faculty to be involved, they will need the slides, in such a way that the slides can be projected, because they won't just work on the reporting. They can actually give you a format to report, but for them to be able to comment, they want to see the slides. So these are some of the things, and I think it would be easier for us to have a unified, a centralized system. I don't know if, but it's something that we could think about. I don't have a problem. I can link up with my pathology colleagues, but I can also see where you are coming from, Dr. Irowa. If some of our colleagues are senior, but that's where our senior colleagues also come in now, Professor Ugo and Professor Bakari and the others, to see how they can help us ginger the pathologists, to... I think Professor Bakari and Dr. Adejumo, they have their hands up, Dr. Shino.
All right. Thank you, sir, for the, I think, really...
They have their hands raised.
Hello?
Yes. Go ahead.
Can you hear me?
Yes, I can hear you.
Yes, thank you very much. I think...
Go ahead, sir. Go ahead. We can hear you, sir.
Yes. Establishing a protocol, it cannot be overemphasized here. We need a guide, a protocol for managing these diseases. I think it is high time now to synthesize all the centers to start using the standard guideline in the management of these diseases. If you look at how this patient is managed, if the standard protocol is followed, I'm sure this patient will have had a better treatment. The MDT, like this one now, I understand the surgeon had a serious challenge on how to convince the patient for the standard treatment. But if they have a psychologist or a psychiatrist to talk to this person to see whether he has some other social issues, that why he refused or he declined from the standard treatment, I think it would worth trying. And another thing is, if this presentation he has called in the pathologist who made this report to now come with the slide on board and then maybe read it while we are watching, and then there are other pathologists on the platform that can now see whether he has done it the right thing or not. Also, even the radiologist shall be the person that reported that MRI should have been on this presentation so that he will give his own input. That is how we can carefully and then correct this kind of anomaly. Otherwise, if somebody presented, give this kind of report, and somebody somewhere is now criticizing the presentation, he may feel maybe slighted and so on. So I think it's important, whoever is making a presentation like this, let him get the reporting or either histologist or the radiologist to come on board with him. Let him present the case, and then the histologist present his own part. The radiologist also present his own part. Then here we can see, we can discuss here, and then make a concrete conclusion on it. And again, this kind of case now is a PET scan will have helped earlier since he refused. If you have done a PET scan, maybe you can see some occult metastasis, maybe around the that is down distal to where the tumor was. Maybe it has even reached to the anal ring. So if we have done that, maybe we'll have seen some micrometastasis around that place. And another thing is this recurrence now that we are talking about. Is it at the anastomotic site, or where? Is it distal to it, or is it proximal to it? Thank you very much.
Yeah, thanks, Professor Bakari. I think
Dr. Adejumo, you can go ahead.
Okay, thank you very much, sir. Just to pick it up where Prof ended, and I want to say that one of our very strong pathologist member here, I think it's from Miniri, Professor Okani. So Professor Okani has been very supportive to this association, and if you can remember, he even submitted a reporting form to this association that we all adopted as a standard reporting format for histopathological review. The reason why I think maybe that has not been an instrument is because we are yet to come up with guidelines as at that time. But as issues like this are coming up, I think we are going to review some of these things during our next ESCO meeting and also present to the General House. Be that as it's been, I understand the problems the surgeon faced with this man. And at this doctor, just like Professor Sime normally advises us, I think we should think of having a refusal of treatment form to be signed by patients after we must have counseled patients on what we think is the best for the patients. Legally and ethically speaking, I think this will even protect the doctor to a certain extent. Then Dr. Erua was mentioning bringing pathologists and radiologists on board. Dr. Erua, in fact, there is no meeting, sir. There's none of our monthly clinical meeting that I personally do not circulate the adverts to the radiologists and the pathologists. But for reasons best known to them, they don't attend. I think I've discussed this thing times with that number with some of our international faculties. Even Professor Ugu has been very supportive. Just last month, Professor Ugu even brought in 2 pathologists from his center. I spoke to them one-on-one, and they promised to be joining us. But you see, at this kind of meeting, we are not seeing them. So I think the approach we are still going to be using is to engage the histologists, the histopathologists, and the radiologists from the presenting center, because they know the challenges they face with the management of that patient. So it will be better for them to present as a group, just like what Professor Bakari stated. And by so doing, I think we will keep on pushing to ensure that...
Recording in progress.
Sir?
No, go ahead.
Okay. Then, in addition to that, the MDT that somebody was talking about, like my hospital, we don't really have everybody on ground, and the Zoom thing is what personally I have been using. I connect with radio oncologists from another center, and there's some other centers like that. We are not more than 5 or 6 at the same time, and we put tests together. And at times, there was even a patient, there was a colleague of mine, Professor Dr. Egwuonwu, if you remember, I had to discuss with you, with another doctor from Canada, and some other doctors from Nigeria, and we all agreed on what to do for the patient. So we shouldn't be limited to our institution. We can always network with ourselves. And I think by so doing, we will improve on the clinical practices. I still want to thank Professor Ugu. I have to say this publicly. Professor Ugu has been so much instrumental in helping us reach out to our other colleagues in other specialties, especially the pathologists. And I want to still appeal to him that he shouldn't get tired of their lukewarm attitude, to still keep on pushing and encouraging them. While we on the ESCO part, we still look at ways of improving their outcome. The reason why we don't want to bring in foreign faculties is that, just like we agree that we want to solve our problem our own way. If you bring somebody from probably UK or US or Italy and all those things, they'll be talking at their level, not minding the peculiarities and limitations we have in Nigeria. So that is why we strongly believe that we should engage our own local faculties. You know, bearing in mind our restrictions, our limitations in so many things, so that we can come with something that is feasible and reproducible in virtually all our hospitals. And lastly, sir, this is your experience that our patients is refusing standard care of management. I have experienced it several times, and with all sense of responsibility, sir. There were two patients that I counseled on some procedures like that, and patients came to decline. At the end of the day, I was amazed to discover that it was a medical officer that was advising the patient not to accept my treatment. A medical officer that doesn't even know anything about surgery. But unfortunately, the patient, the two of them refused. And after some months, they came back with a worse clinical situation. And there was nothing I could actually do. And that was when I got to know that it was a medical officer that was misleading them, a doctor. And I was expecting the doctor to even reach out to me so that I could explain to him. But he was busy giving the patients wrong information and advised them not to accept the chemotherapy and all those things we wanted to give the patient. So these are some of the confounding situations we find ourselves in. I hope with further enlightenment and engagement of our people, things will get better. That is my submission for now. Thank you very much, sir.
Thank you very much, Dr. Adejimo. I concur with you entirely. I think we should solve our own problems ourselves. We can actually, regarding MDTs, MDTs doesn't have to be local. It doesn't have to be within your hospital alone. You can discuss with people outside, specialties outside your hospital. The only issue with MDTs is the involvement. A pathologist must always be involved as well, because they need to check the slides. Somebody may say it's a T2 disease, another person may say it's a T3 disease, another person may say, oh, the circumferential resection margins that is involved, another person may say something different. That is why it's usually good to have more than one person doing anything. Like the saying goes, 2 heads are better than one. Ultimately, it will better, the patient will be better off at the end of the day.
Yeah. I know Professor Ogo had raised his hand earlier on. I don't know if he's still there.
I think he raised up his hand.
Okay.
I think
he's ready to talk.
Yeah. Okay.
Yeah, go ahead, sir. Go ahead, sir.
Yeah.
Go ahead.
Thank you very much. Good evening, everybody, and thank you to the presenter. I think this is quite a very challenging case, and I must say that I'm impressed by the work that the presenter had done. I have also listened carefully to the contributions of everybody, and I'm very much in line with what had been said. However, I know that it will be difficult to bring the pathologists who perhaps made a mistake, like in this particular case. I suspect that they will not come. If you ask them to come and talk to us, they will think that we are on some investigatory mission, and which they may construe to tarnish their image. I think that what we should be thinking now is how we can make this society to be quite robust to solve the problems and challenges that are peculiar to our country and our practice. I am therefore after looking at everything that has been said this evening, I think I can see a pathway to solving this problem. One is that our monthly meetings, if we make sure that our monthly meetings, we're able to keep to them regularly, that's number one. Number two, if we divide or create a special time towards the end for MDT, we now call it a national MDT, whereby surgeons from various parts of our country can bring in the problems that they are facing. Because we are going to be meeting monthly, if they defer the operation by just a few weeks, to be able to talk with us, to help them clear their doubts and move, and then they can go on. And then after surgery, they can still come back again, and we keep on discussing. Some centers, like we've said, do not have the MDT. And the ego problem comes. Some people will want to say, oh, look, I've been operating for decades. Why should I come and be controlled by an MDT? So I'm suggesting, if it is approved by the executive, that this society, Nigerian Society of Colorectal Disorders, should also become a national MDT. By so doing, we are offering so much to this country. This would be a peculiar society that not only gives an international quality seminar, but it also serves as a national MDT for this country. I'm telling you that with time, people will begin to come in here. But then I must also mention that it must be in such a way that people feel safe to come. Like now asking that the fellow must come and explain to us what he did. No. We're not in a position to do that. No. Once we start doing that, nobody comes here anymore. So I'm thinking that, like we've been told, there is a reporting format for pathologists for colorectal diseases, particularly cancer. I think that particular one that was presented to us, we need to see, because I'm thinking that reporting format has been updated. I can't remember the last time I checked, but I compared. It appears to me that something new has also come into it, so that we will also be up to date in what is going on. But we can start with that and then carry on. Whoever is coming to present to us, please, we want you to not only show us the CT scan, MRI, show us also the slides. The pathologist in your center will not deny you access to the slides of your patient. And you can take pictures and then come and present to us here. If the pathologist agrees to come, that is well and nice. If they don't agree to come, we have the material. And those who are here can now discuss. I think that also that I will make more attempt to bring in the pathologist again. I will go to them, and on the day before our meeting, I will keep talking to them. On the day of the meeting, I'll keep calling them. I believe that over time, I may be successful in bringing one or two to be regularly coming here, because all of them promised me they will be coming. But from what I'm seeing, they are not coming. But I'll keep. Sorry for taking so much time and of yours. Thank you very much.
Thank you very much, sir. Thank you very much, sir. We all share we'll all agree with all that you've said, sir. I'm not too sure we have other questions.
Yeah, Dr. Shino, I just wanted to concur with what Professor Ugo said there. That the essence is not a blame game or a blame apportioning thing. So it's not like to bring the pathologist to grill him here. And if true to be said, the pathology result did not affect the outcome of this patient.
No, sir.
The pathology result was something that was following the surgery. So it didn't affect it. And again, just to make a slight comment on Professor Bakari's request for the PET scan. I mean, again, these are all things that will increase cost, at the expense of doing the right thing at the first time. Because the standard of care, people that have mid-rectal tumor should have neoadjuvant chemoradiation. At least even if you can't get a proper MRI to show your circumferential involvement, but I think it's still a safe thing to downstage and the lymph node status and the tumor status prior to surgery for patients with low and mid-rectal tumors. So that would be my view, because even if the MRI, even if the PET scan showed activity and increased bioactivities in the pelvis, still the quality of surgery that is important. Are you able to do your total mesorectal excision at that stage? Or this kind of patient will he have agreed to have the proper treatment of neoadjuvant treatment at the beginning? That would be the thing. I mean, Dr. Egwuonwu, I think you did the best to, within the facilities available, but this really brings it to the fore now that we need to do something on this platform. And for everybody, we all have the phone numbers of everybody on the platform. If you go to your WhatsApp platform, you see that everybody, Professor Ogo's number, Dr. Oshinowo's number, Professor Adejumo, everybody's numbers, Professor Bakari are here, so you can ring anybody, you know, and just talk to a colleague and say, okay, this is what I have, what should I, or what can we do? So let's try and talk to one another there. And I think there is virtue in doing that. I know we come from a culture where some people are so, you know, ego takes a better part of it. But I think things should begin to change. You are bigger, you are better when you discuss with your colleagues, you know. It doesn't make you any less.
Dr. Shinawa, are you there, sir?
Yeah, I'm there.
Okay. I think Dr. Egwuonwu has finished.
Yeah, I think I actually concur with what Dr. Egwuonwu said. All that he said, I think we need, unquestionably, I think what this presentation has just shown us is the importance of an MDT. We should have one MDT in one way or the other in all our institutions. How we are going to do it? I know in some centers it may be very difficult, but in some in my center it's not too difficult at all. It's not too difficult because we all do so many things together. I think in most centers that may be difficult, we must find a way of it, because that is the only way patient can have the best treatment available. The standard treatment, rather. The standard treatment. That's the only way the patient can have standard treatment. If the patient is not having standard treatment, what just happened to this patient will keep on happening to all patients. That's the bottom line here. I think we need to find a way of creating MDT in most centers. MDTs, like I rightly pointed out, can easily be done by Zoom. And you have to bribe your colleague. I'm not saying you are going to bribe them. Everybody wants a good outcome for all patients. The pathologist too wants a good outcome. The pathologist wants a good outcome. No, never so much as the pathologist has not seen the patient. They want a good outcome. The radiologists too want a good outcome. They want to hear that, oh, that patient did very well. That patient you operated on did very well. It was based on the report you sent to me. I made a decision based on what you told me, based on what we discussed. I was the one that operated the patient, but you are not the only person here. It's a teamwork. I think the earlier we also realized that managing patients is also a teamwork. It's a teamwork. It will go us a long way in offering our patient standard treatment. I think that's my submission here.
Prof, I have a suggestion, sir. Whether it's something we can think about, sir. The
Go ahead,
society,
sir.
in some national conferences like the ASCAF conference or West African College of Surgeons conference, where all these specialty come together and sit down, it may be good if the executive would consider having a slot where they make presentation of
I lost you, sir.
key into it, so that when you go, okay.
We lost
Can you hear me
you.
now, sir?
We can hear you now, sir.
Your line is breaking. Yeah.
Okay. Yeah, I'm saying it may be a good idea if the society could key into national and regional conferences like ASCAF, for instance, conference where the whole surgeons, pathology, radiologists, they come together to have a common meeting, or like the WAS conference where they all come together under the same roof to have a common meeting. And if at that meeting, the society makes a presentation on the value importance of MDT, reference some of the finding we get from our presentation, and help them see that this is a standard of care. There is of no value that a pathologist is reporting, showing out results from the center, and is not even working with the surgeon that manages the patient, and the surgeon is not working with the radio oncology that also may play a role in the patient, that the way forward, the best way to go is this. When we hear this message at the same sitting, and people go back home, you call on your colleague, look, we're at the conference, you heard what they said, let's come together and do something. They seem to have a common goal, a common pathway. But when you call some people, it's as if you are trying to I don't know how they see it, as if you want to eat into their time. They don't even appreciate how valuable it is. After all, they're giving your pathologist, but go ahead and do what you want to do with it. But if at that meeting, you make a presentation that is so strong that everybody sees that it is not enough just for a pathologist to send out a report. And it's not just enough for a surgeon to accept a pathologist report, that everybody must come together and play a role in making a decision on the final treatment. Probably when the message start coming 2 times, 2 consecutive years, over time, any center may end up being able to establish this effortlessly because we've all heard it from the same source at the same time.
Thank you. Thank you very much, sir.
Yeah,
I think,
sorry, 1 minute, sir. Can I just respond to what Dr. Egwuonwu said just now?
Go ahead, sir. Go ahead, sir.
Yes, sir. Thank you very much, sir. I was privileged to be at the Surgical Congress sometimes in June this year in Lagos.
Yes, I saw
the
you.
Surgical Congress, yes. And I think it was one of the things that was discussed at that meeting in one of the sessions. Unfortunately enough, the conference was poorly attended, but we intend that by next year, we are going to improve on the publicity of the Congress. The Congress is anchored by the Association of Surgeons of Nigeria, which is an umbrella body comprising of all surgical specialties, irrespective of what we are doing. Everybody comes together under that umbrella, and I think that is the best forum for us to discuss matters like this, because whether National College or West African College, everybody comes together under that Association of Surgeons of Nigeria, and the program is actually fashioned against the American Clinical Congress, so in which everybody comes together. Again, by January, we are going to start the sensitization so that next year's attendance will be better, and some of these very sensitive issues, understand, will be brought up during the meetings and discussed there, just like what you have advised just now. So I just want to acknowledge your submission, and again, I'm going to pass it across to the president of us, and that's Professor Ademuyiwa, who is also a pediatric surgeon anyway. So we are going to work on that and also see how we can get everybody along. Thank you very much.
Yeah, maybe something else I will recommend is because this is a serious governance issue. If the provost or I don't know the CMD of this issue can be brought to the CMD of every institution to say this is the minimum standard requirement. We are talking about drawing up protocols. This is one of those minimum standard requirements of it doesn't require any equipment or money. It's just for people to sit together. I mean, I'm shocked if a pathologist gives you a report and they go and do whatever you want to do with it. That just means they don't understand the import of their contribution to the system. Maybe the other challenge I will give is maybe to somebody like Dr. Lassie to actually do a deep dive into the value of MDT. I'm just looking at my Googling it here, and I can see a lot of articles here that, where it has been proven and validated the value of, MDT in colorectal cancer. And if we can present those cases to the CMDs of each teaching hospital or each federal medical center, and then they can actually instruct that this is something that should be carried out. It's part of the best care for patients in the hospital, and everybody can be brought to the table, and we can discuss. Maybe once a week, you discuss 2 or 3 cases that have gone through the pathologist and everybody, and we sit together and make a decision. It's something to consider.
Sir, maybe I should offer you this information. I think I'll try and get a document. There's a document from the Federal Ministry of Health that says MDTs should be established in institutions. I'll look for the document and put it down. It's from the Federal Ministry of Health. Yes.
Okay. Yes. So once you have
it. Well, would you allow me, sir, to just say a word on this? Just a word.
Yes, Prof.
Go ahead, sir. Go ahead, sir.
Thank you very much, sir. Thank you. I think that I want something that is practicable and something we can run with, hit the ground running immediately. If it is agreed at this meeting that Dr. Guare will chair a small committee that will write up, bring up something that we can present at the West African College of Surgeons conference in March at Freetown. This will no longer be a Nigerian issue. It will also benefit all the West African countries in the sub-region, because what we are seeing here is what is going on over there. That's why I'm saying that the functions of this society, they are quite beyond what we have put down on paper. And I'm thinking that this is doable. Already Ochonma has some materials from the Federal Ministry of Health that are pointing this direction. And already, you have Googled already and you can see a lot of materials. Olasi is there. And the other people, I'm around. I could also join the team. And if we're given a short time, we come back here and present the material we have. And then thereafter, we submit to the LOC, and we can work and ensure that it is given a prime time. And this discussion, once it is presented once, then we can be having follow-up discussions at subsequent conferences. Thank you very much.
Thank you, Prof. Yeah, Dr. Ochonma, what do you, sir?
Thank you very much, sir. Thank you, everyone. I think we've come to one agreement: the importance of MDT, the management of colorectal cancers, and how we are going to have this. How we are going to have this entrenched, make it a standard in the management of all colorectal cancer cases in Nigeria. I think we must have a way. I think the most important thing is we must try and start one thing or the other. Like what you rightly pointed out, maybe we present at a meeting, the importance of MDTs, how successful it has been in other centers, in other climates, how successful it has been in other climates, and how it will ultimately benefit our patients. I think we should start presenting that in most, whenever we go for conferences. I think we'd go a long way. And we also interact with management in our respective hospitals. I think we'd go a long way.
Yeah.
Hello?
Yeah, we can.
Can you hear me, please? Yeah. So, I mean, I think that's all I have to say. I don't know whether anybody has any other contribution.
Looks like Professor Bakari's hand is raised up. I don't know if
his hand had been raised previously. His hand had been raised. He had not dropped his hand. His hand was raised. Yeah. His hand had been raised. It was raised previously, just before he answered before he spoke earlier.
I think we can all agree there's been a very robust discussion this evening regarding the role of MDT in managing our patients. And there are a lot of action points that have been noted that we would carry on and take appropriate steps towards making it become a reality. It's already past 9 and we've exceeded about an hour of the meeting. There are no other items on the agenda, but I'd like to ask the president if he has any announcements or information for us before we call the meeting to a close.
Thank you very much, Dr. Wadiyeye. The only thing I want to say is that next month, November, is going to be our end of the year general meeting, and that will be the last meeting for the year officially. And also, we are trying to we try to give an update to the House of what we have discussed this night, because we are still going to have some subcommittee meetings in the next 1 or 2 weeks. So we are going to update the House about our activities on those subcommittees and have our general end of the year meeting as planned. So aside that, I think I don't have any other.
So again, we'd like to thank all our teachers, our professors, our senior colleagues who have joined this meeting and are giving erudite advice. Thanks once again for our presenter, or to our presenter, I beg your pardon, for the presentation and for generating this discussion. And thanks to everybody for attending and for making this meeting happen. On behalf of the society and the schools, I'd like to wish us a wonderful marriage. Good night.